we are discussing the block of upper limb. So it's a popular block for hand and forearm surgery. You can say below the elbow, and above the elbow it may make problem. And the benefit of this is less complication as compared to supraclavicular and interscalene. There are known complications for interscalene. Phrenic nerve is not a complication. It's a effect, not the side effect of the block, because T3, C5 is always blocked in interscalene, and it's our aim to block the C5. So it's a side effect, not a side effect, it's the effect. And there's a known complication of supraclavicular, which is pneumothorax, which is a very dreadful complication. But this block is devoid of this complication. So the plexus is formed from C1 to C5 to T1. At the level of the axilla, it gives its branches, median, ulnar, and radial nerves. And they all three are named according to their position in relation to the axillary artery. So median is median, ulnar is lateral. Ulnar word means lateral, and the radial is posterior. Posterior is related to anatomy, and posterior is related to nerve stimulator technique. But when we use the ultrasound technique, this word is changed. Because if you put the ultrasound here, then outer lateral becomes upper and posterior becomes lower. Mm-hmm. Lateral becomes upper and second type is down. So the ergonomics is different. So I will discuss how we name them. It's simple. Musculocutaneous nerve lies outside the sheath. This is again a compartment, not like the interscalene, but it's a neurovascular bundle. In interscalene, it is the interscalene groove. And it's again a compartment, but in this space, in the axilla, they are a neurovascular junction, which is a closed sheath. So they say if you inject in the closed sheath anywhere, you can block 3 nerves. But now we have ultrasound techniques, and we can specifically block 3 nerves separately. Or there are 3 techniques I will describe, and intercostobrachial and medial cutaneous nerve arm blockage needs a separate block, which I will discuss, because we did 2 cases yesterday from this medial. They were operating on this medial side. It was intercostobrachial and medial. It's very easy to block, I will tell you. This is the dermatomal. You can see the T2. This is medial side up to just reaching even almost the elbow. Intercostobrachial and medial cutaneous nerve of arm. This is T2. This is not the part of even the brachial plexus. It comes T2, is thoracic, but it supplies the medial part. So we have to take care of it when we do surgery on this area. Median nerve enters the arm inferior border of teres major. There are 2 major. Let's see between 2 majors on the groove, on the humerus, and this lies anterior to it. So it enters the arm in the inferior border of teres major and descends with the brachial artery on the medial aspect of the arm between biceps brachii and brachialis here. So it's medial to the artery. The name median means medial to the artery, it implies. Initially, it lies lateral and then crosses over the artery and comes to the medial side of the lower limb. The lower part of the forearm and arm. So if you trace down, if you are in doubt, what is this nerve, you can trace down. So that the ulnar will be going to the ulnar side and passing the intramuscular septum, going back. The median is coming to the median. And the radial is posterior. You cannot see in the mid-humerus radial in front. So this is the anatomy of the median nerve. And if you see from posterior, which is upper one, you will see it only in the arm from posterior. And if you go to the anterior, median nerve comes in the anterior. in front of the medially, it runs down, and you can see it is coming in the hand and supplying the 3.5 fingers and the lateral fingers, medial fingers, from thumb, index, and ring finger half, and ulnar supplies the 1.5. And opposite side from the back you can see radial and then ulnar. So this is the medial nerve anatomy, and it takes all innervation from C5 to T1. C5, 6, 7, 8, T1, it carries all the nerves, nerve root. So the second nerve is ulnar nerve. Ulnar nerve runs medial to the artery. It is almost near, maybe at 2 or 1 or 2 o'clock position. This medial nerve is at 11, and the ulnar nerve is at 2 or 3, and they are between artery and vein, axillary artery and vein. So this is a tricky position. It's not easy. We have to understand when giving the axillary block. The trick is to give at 11 o'clock by hydrodissection 5 ml. It will separate the arterial nerve. If you are able to separate the arterial nerve, you can go between the artery and nerve, and then the nerve is behind, ulnar nerve is behind it. But the beauty of this block is if you increase the volume more than 5 ml, it will spread all over the neurovascular bundle. So Dr. Nasser was saying, I will use high dose. This is right. If you use 30 ml anywhere in the neurovascular bundle, it will spread. I was discussing with him, no, why do you use 40 ml, 30 ml? But he is right. So if you use 35 ml is recommended in blind techniques. If you go into the neurovascular bundle, give 35 ml. The dose is from 15 to 40 ml, 0.25%, which is already in a dose 2 milligram per kg. 0.25% means 200 milligram. So you can use up to 40 ml even. So if you trace the ulnar nerve down, it will pierce the intravascular septum. It will go posterior to the medial epicondyle. So if you can trace down, it will go medially. If you go to the trace the medial nerve, it will go medially. And if you trace the ulnar nerve, it is not coming in the anterior compartment of the arm, it is going behind, in the radial groove, and coming from here. So this is the surface anatomy of the ulnar nerve, and it carries C7, 8, and T1. So if you see from the posterior, which is upper, you can see the ulnar nerve through and through. And if you see the lower down, it's coming from here and going back and coming then again in the anterior compartment, running with the important point is running with the ulnar artery. So you can locate it, and in the forearm, almost more than half of the lower half of the arm, it is accompanying the ulnar artery. So you can trace down, you can identify it. So radial nerve. So radial nerve again carries a fiber from C5 to T1, all fibers. Medial nerve carries all fiber. Only ulnar nerve is last three nerve root, anterior nerve root. The radial nerve lies deep. Deep means posteriorly. When you use the ultrasound, you will use the word deep. Deep means lower part of the ultrasound. And behind the artery, lower side and behind the artery. But if you use otherwise it is posterior. Anatomically it is posterior. And if you use the nerve stimulator, you will use the word posterior to the artery. But if you use ultrasound, your probe is here. This is deep or lower. So the terminology is different in different techniques. So in ultrasound, we are using lower or posterior to the artery. Its position may vary from 6 is the lowest most. It can vary from 7, 6, 4, 5, and maybe at 4 o'clock position. So it varies. And this is most important point, and it is the most common reason of failure in the past, because we were using blind techniques and we were using ultrasound technique. Anatomy is variable. Now they have found, I will go to the musculocutaneous, 18%, it is accompanied with the medial nerve. It is not in the coracobrachialis, brachialis. I will discuss this in a second. This is radial. It supplies the posterior compartment, triceps muscles, and it supplies the extensor compartment and 3.5 lateral nerves and this is cutaneous dermatome. And if you see the from the front, it is supplying the some part of skin, and you see some part of skin down. So musculocutaneous nerve MCN penetrates coracobrachialis from here. This is coracoid process. Coracobrachialis arises from coracoid process and attaches in the humerus. So it pierces the coracobrachialis and run between the brachialis and brachialis and biceps brachii. It's very easy, and it is the most hyperechoic nerve of the body. Usually it's star shaped, so maybe triangular, but usually it's star shaped. You can trace it easily between the two muscles. So it enters the forearm and continues as a lateral cutaneous nerve of forearm and supplies the lateral compartment. And it may reach up to the even the synapse box, and may go earlier. This is I was saying the reason of failure means this is variable anatomy. You don't know where is the nerve, and you just have a average surface anatomy from the nerves you can identify. But with ultrasound you can specifically identify exactly where is the nerve lying. This is a study. Approximately 18% of the median musculocutaneous nerves are along with the median nerve. They are not separate. If you block the median nerve, means musculocutaneous nerve is blocked. But this says if you don't find musculocutaneous nerve, don't worry. It's somewhere with other nerve, and it's very variable. So this was the reason in the past. So if you don't find this musculocutaneous nerve, don't worry, it is accompanied with the median nerve. So if you block the median nerve, it is done. This is the area of supply of the musculocutaneous nerve. You can see it's only lateral cutaneous nerve arm. Lateral cutaneous nerve arm supplying, nothing more. And it's supplying the muscles of anterior compartment, brachialis, coracobrachialis, and biceps. And general points is there is a large anatomical variation, and extended scanning up and down is recommended to locate the nerves. So if you locate the nerve, this is ulnar, it may be median, but if you go down, the ulnar is going to the medial epicondyle, and the median is going to the lateral epicondyle. So it is recommended to go up and down, and you will not find the radial nerve. Radial nerve is going posterior to the groove. So there are two nerves in relation to the artery. If you go down, one is lateral going to the lateral epicondyle. This is median. If it is coming to the medial epicondyle, it is ulnar. So this is recommended to don't see one look and say this is ulnar, this is median. Just trace down and up. It's not surprising ultrasound guided has a high success rate because of this reason, because you see directly. And it also reduces the risk of vascular puncture and reduce risk of block onset time, because you are exactly giving on the perineurium outside just beside the nerve you are injecting. In ultrasound and blind technique, you may be away from the nerve stimulator may be stimulated, and you are not exactly on the side. And in the nerve stimulator, you are on the one side of the nerve. In ultrasound, you can make a donor. Just sometimes they see 3 cc is enough. If it is making donut from one side and from other side, and 3 cc to 5 cc is enough. But recommended is 5 cc for big nerves, 5 to 7 cc. And some people, old people, they use 10 ml if the dose allows them. So the axillary block is excellent for beginners. There is only one complication which can occur, it's entering in the axillary artery. And it's easily managed by pressure. And in the past, I remember maybe 20 years ago, my senior were using transarterial technique. They were going through the artery. Okay, this is confirmed. Like a spinal. When CSF comes, you are confirmed this spine is working. When you are going, the blood comes, okay, go ahead. Pass the nerve. And if you go behind the artery, means your radial and ulnar is done. And maybe median is spared, but ulnar and median is done if you pass the artery, because they are behind the artery. And they are lying on the epineurosis of the teres major it's a lady between two majors. Latissimus dorsi is major and pectoralis major. So this is the groove. They are sitting on the groove and surrounded by a neurovascular bundle. So if you enter the artery, means you are in the neurovascular bundle. If you pass the artery, this is not recommended nowadays. It's not the routine technique to go through the artery. Not good, because we have now ultrasound, you can see. But if for accidentally it goes, don't be relaxed. Don't go in panic, just pass the artery and come back. So if you pass the artery, you will make two rent. If you come back, it's one rent. This is accidental. So it depends on situation. Where is your radial artery? If it is at the 9 o'clock position or 3 o'clock position, you may need to go through the artery. You have already ruptured. I do not recommend this. You should come out. But sometimes you are unable to send your solution to the radial, which may be posterior, which may be 3 o'clock, which may be 6, 4, 5, 6. The normal position of radial is 5, 6, 7, maybe 4, rarely, but not 3, and not even 8. So it's easy to block the radial nerve. Most easy block is radial nerve. Go below the artery. So I will describe the three techniques and you will understand how it works. So anatomical location, terms of location are confusing with the axillary block. So if you have anatomical orientation in your brain and you have a anatomical orientation of ultrasound guided this nerve locator technique, then you are confused. If you are a beginner with ultrasound and you are used to the nerve stimulator technique and anatomical orientation, these will make you confused. What is posterior? You are saying down, 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 down means this. Here down means this. Up means to the brachialis. So they say there's no way, we have to change the words. So they are changing. Lateral means above. Lateral means above. And above means lateral. Posterior, down means posterior. So it's easy to remember, not confusing, but for beginner it sometimes makes problem. Indication is elbow, forearm and hand surgery. Contraindication are same like all, some refusal of the patient, local infection and allergy to local anesthetic. Relative contraindication are coagulopathy and systemic infection. Equipment, short wave regional block technique, they recommend 50, but I put question mark, I am using 100 because I am going from the deltoid or biceps. You can go from here, you can go from here, and you can go from here. There are recommendations to go through the deltoid and through the biceps. There are 3 recommendations. I was with the Bruno in USA. He described me how to do this. This is does not make any difference, but you see it's clean part. Number 1 was clean part. Number 2, your needle is stabilized. If you go near the artery, you will go maybe 1 centimeter. You can enter. It's easy to enter at 1 centimeter, but it's better to go 4 or 5 centimeter. Your needle is resistant. It will not move. So he described, I will tell you. So local anesthetic solution is recommended is 15 to 40 ml. Dose within limit. So I recommend to take 20 ml of 0.5% or 40 ml of 0.25% in a 70 kg. And then if you want to increase volume, put the saline whatever you like. So the absolute dose should not increase more than 3 milligram per kg. Sometimes the patient are low weight, maybe 50, 40. So you can vary the dose, but everybody knows what should be the dose of 2 milligram per kg.
If you calculate, my way of doing it, and if calculating and doing the safety margin, like if the patient weight is 80 kg, for example.
Take 160.
Then
60.
160, 160.
Yes, 160.
80 milligram. You wanna know how much volume?
16
and
cc.
If you multiply with 0.8, this is for the 0.5%. For 80 kg, you can go up to 64 ml.
Yeah.
64 ml of 0.25.
Yeah.
Or if you multiply by 0.4,
32 ml.
32 ml,
Yes.
this is for the 0.5.
Yeah.
Either you multiply by 0.4 or 0.8.
Volume is fixed. Volume you have to determine before giving that block. So for every block there is a different volume variation. Now they are going to lower volumes. So the recommended dose is 2 milligram per kg for bupivacaine, and the maximum dose in 20 ml is 100, which is for 50 kg. But our patient may be 70, so you can increase 120, 140, and then if you want high volume, dilute it. Yes. Yeah. 0.25% takes long time to work. 0.25% takes maybe 15 to 20 minutes to work. Sometimes we are in a hurry. 2.25 we are talking about. Adding adrenaline is another issue. I am not adding in bupivacaine, but in xylocaine we can use this, and we can go higher
Is
doses.
it going to be a factor if the onset time, if you give high volume or low volume? I don't think so. If you give lidocaine, it will work fast.
Yeah, fast.
Smarcaine, regardless of the volume, I think it's going to work the same.
Now, if the volume is high and
higher volume,
yeah,
means more distribution.
no distribution.
Okay. So it overcome sometimes
Spare nerve
some
can.
failure of the operation of the needle for the beginner. Okay. So higher volume,
More
Will
distribution.
will increase your success rate, but
Yeah.
not
Yeah.
the onset of.
no, also can be overcome by use of lidocaine.
Lidocaine.
The
Lidocaine.
mixed lidocaine with
Yeah, this is
lidocaine
It's compounding.
give you more than onset. Okay. And
They use the word
Yes.
for compounding, means combining two
Yeah.
two local anesthetics, two
What is the-
quick onset. And then we use sterile gloves. These techniques are aseptic, not sterile technique. Even your IV line is more sterile technique than this technique. This is like intramuscular subcutaneous injection. So if you pass arterial line to be more aseptic, then going block, the most important thing, you should not touch the needle. Ultrasound needle should not be touched by the hand, by the gloves, or by anything. And your area where you are doing the prick, it should be with chlorhexidine. And we have available chlorhexidine with alcohol. This is the best solution which is recommended. It should be scrubbed and allowed to dry before going for block. And then you can use iodine, alcohol, but it's recommended is chlorhexidine. So we use also syringes. General technique. General technique, we use IV access, applying monitors, full resuscitation equipment should be available. Even intralipid should be available in every technique. This is a lipofundin or a what solution. Patient should be in position supine with arm abducted and forearm supinated. And it should not be over abducted. If you do the over abduction, the head of the humerus will press the artery and there will be less flow. You will not be able to see the things clearly. Do not use excessive abduction. It will obscure axillary artery and limit the proximal spread, because you will block the. We allow. Previously, they used to press the neurovascular bundle from the below by giving 30 ml. The drug should go up and near supraclavicular block or infraclavicular block. Pain or paresthesia may be associated with intraneural injection. So pain, when you are find resistant to injection, please stop. Pain is a sign of intraneural injection. Nowadays, they recommend the attachment of nerve stimulator at 0.1. At 0.1 for exclusion, not for inclusion. To not find out the nerve, to exclude, you are away from. If you are 0.1, means you are not in the nerve. 0.1, the nerve will give you twitch, and if you are near 0.3 is the minimum. For ultrasound finding the nerves, it's 0.3 to 0.1. Keep it 1 and then decrease to 0.3. Come near the nerve. But when you are doing these technique ultrasound, attach the nerve stimulator and keep it the minimum 0.1. 0.1 means lowest current. So if you are in the nerve, it will give you twitch, and if it is giving twitch, come out. So this is for exclusion nowadays, nerve stimulator. Not before it was finding the nerve locator. Now exclude the nerve. So this is safety precaution, but people are very confident nowadays. They are not using. It is cumbersome. So chlorhexidine solution is recommended. This is the formula to appear in exam of Royal College in Ireland and England, Sillimrage. So they want to listen like this. When you appear in the NHS exam in Royal College of England or Ireland, I appeared there. And there were courses we attended. They said, this is what the examiner want to listen from you. You know what you need. For every block, you should have a facility for GA, atropine ready, the lipid ready, everything ready. But he want to listen like good light. See, Selim, S means sterile technique. Although we are using aseptic technique. Oh, sorry, this is sterile technique. This is right. Sterile technique. And then light source, good light source, then IV cannula, then monitor, then resuscitation, then assistant, then ability to convert the things in GA. You should be near the machines, and the area should be compatible to start GA. So this is the Selim range they want to listen from an NHS exam like this. Because I already described this, IV access, full resuscitation, patient should be supine like this. But what they want to listen, Selim range. So anybody going there? Ergonomics is inline alignment of the patient, operator, and ultrasound. Ultrasound should be in front of you. When you are doing operation, ultrasound should be in front of you. You should not see like this, moving. So this will make you problem for you. So it is acceptable to perform the block from here, come from the front, or go from the back. Both are acceptable. I like the posterior approach, come from the behind and go like this. But some people come and they put the needle like this. For me, this is easy. But it depends on the person, how he's trained, how he likes. So it is a training. And how you see your senior doing and you start doing things, now the other side is difficult for you, which may be easier. So it depends on training. Before doing any block, place the transducer in this. Place the transducer in this position. So I can show you, it's very good to see, but it's, everybody knows, no need to describe. Just put it here, go down, and here. And what I learned, it's innovation, I go like this. So your needle will be 6 to 7 or 60 to 70 centimeter inside from here. What is the benefit of using this, going lateral to the artery? I am using this. The recommended is this, 90 degree to the. There are three benefits. One benefit is your needle is fixed. It's going 6 to 7 centimeter or 60 to 70 millimeter inside the muscle, and you are seeing the path where it is going. It is stabilized. Needle is stabilized in the muscle. If you go near to the artery, if you penetrate near to the artery, your needle may be moving and there's a big movement. Here your needle, one point, it's a long path. You are going from the long path to reach the artery. Artery is at this end of the artery is this end of your transducer. So you are coming from here. So, and the second is the movement of your artery. If you go to the routine technique, you have to make 30 degree angle. If you make more than 30, your needle will not be visible. If you make more than 30, you cannot see the needle. If you make 30 or less than 30, you will see. But if you are coming parallel to the needle, you will see 100% cases. This technique will allow you, your needle will be coming 100% in your probe line. So it's easy. The third point of benefit is you are lateral to the artery. You are coming like that, this. So your probe is coming and like this. So there are less chances. If you come 90 degree to the artery, there are chances you may penetrate the artery. You can see the difference in epidural, lumbar and thoracic. The lumbar, if you even touch, you will move on the epidural space. Do you understand this? In lumbar, it's straight. In thoracic, it's parallel to the epidural. Same formula here. You are lateral angulated to the artery like this. So you are coming from this. If you try to penetrate, it will give you little excess. You can go 1 millimeter, 2 millimeter, it will not enter the artery. But if you come straight, there are more chances. So it's a theoretical also.
But the ultrasound will not be the classic
yes.
view. It will be different.
So
it's not will be.
No, it will be same. If you go like this, this will not change the position of artery. This radial will be posterior, and ulnar median will be anterior, and musculocutaneous will be in your path. The benefit musculocutaneous is direct in your path.
Yeah, even if you make it parallel, musculocutaneous is the first thing you see if you do it from up. But if you do it from down,
Yeah.
you will find it will be way behind
You
that.
see, for
And it
for
depends on you
yeah.
go up from.
musculocutaneous is most easy. You go like this and put it like this. You will find enough. Go like this, reach the end, and just go like this. You will find a star-shaped structure. So always perform preliminary sonoanatomy before making the sterilization or putting the gloves or going for the block. Preliminary sonoanatomy is must. So you will know the orientation of nerve before going for the block. So and then you decide what I have to do. And color Doppler is also helping. Sometimes there are vessels in the, usually there are two, axillary artery and some maybe you find some other artery, maybe three, or maybe small veins. So it's better to go use the color. So it will give you access, you are not hitting the artery. Or, and then some people like our friend who is giving very high pressure. So all veins are collapsed. You cannot see the veins when you use the pressure. So use the pressure is not helping in this block. Yes, of course, in this tape block it helps. You can make the position. Tape block it helps, but in this block it will collapse all the veins and you will not see any veins and your needle. And then whenever you give local anesthetic solution, please aspirate, suck, give 1 ml. See, or it is command of the operator 1 ml, 2 ml or 5 ml, but we don't give 5 ml straight, just suck and then give 1 cc, see where it is dispersing, and then according to the command of the operator you can give 10, 15, 20, whatever he asks. So on the lateral side of the axillary artery, identifying biceps brachii in scan, it is above and coracoid lateral. Lateral means above. When we say above means lateral. This is lateral. Musculocutaneous lies in coracobrachialis proximally and pierces through the distally to the biceps and coracobrachialis. Deep to the artery means lower down. Deep to the artery means lower down. Means posterior. I discussed with you. Block conduct. Implant technique has the advantage of better needle visualization, better needle accuracy. It's preferable to approach from lateral side. This avoids needling through veins because vein is posterior or lateral. So if you come from here, you will not find the vein in your artery. It is beside. It's not away from you, but it's beside. It's not coming on the vein. And insert the needle through the skin on the lateral side of the probe at an angle of 30 minimum. So I put the question mark on this presentation because I'm using 180. I'm going parallel to the probe. So it's easy to visualize. You can see all the tip of the needle and all the needle at one time. Pass the needle in the lateral to the medial direction from above to down or from lateral to medial, approximately 60 degrees. Needle reinsertion may be required. It is required. There are 3 techniques, so it varies in every technique. So this is the frontal technique in which we are in the lap of the patient, and some people come from the back of the patient. And this is the position of the nerve. Most common, what's the time now? 40.
41.
Okay, we will finish in 5-7 minutes. Most common relation are median nerve at 11, ulnar at 2-3, and the radial at 6-4 or 6 ocal arc position. If you identify all nerves, inject 5 ml, 5 to 7 ml to all 4 nerves. So you are injecting 20 to 20 ml around minimum, or maybe 25 to 30 ml to inject, localize every nerve. And use hydrodissection. And in this situation, if you localize 3 nerves, you have to do 3 redirection. Go here, then go down, then go to. But the skin prick is single. So come back, and from same you can redirect. This redirection may cause damage to the artery or nerve. And pay attention to local spread. Local must see under ultrasound your drug is spreading around the artery. If it is spreading around the artery, your 3 nerves are blocked. If you can see under ultrasound, your fluid is around the artery, forget nerves. You did your 5 ml 7, 5 ml 7, 5 ml 10 ml, whatever you decide. And in the last you find your artery is surrounded by the fluid, means you are done. So see clearly the star-shaped musculocutaneous. This is separate nerve, you have to block the separate. This is the position. You see, you are coming from, you are coming from there. This is median nerve, and between the artery and the nerve there is ulnar nerve. So this is critical. If you go from above, between the vein and the median nerve in this anatomical model, it may vary, it's not fixed. So if you put 5 ml between the vein and the nerve, it will give you a space. You go inside, if you reach the artery, or you can go between the artery and vein and try to reach the ulnar nerve. So 5 to 7 ml. Then you come from there, and this position you find is 3-4 position. This is 3-4 o'clock. The radial nerve. So if you come there, below the artery, touching the smaller artery, if you give 5 to 7 ml, it will reach the posterior and radial nerve. And then you can increase the volume, and you have to see the volume. If fluid is moving or available all around the artery, means you are all 3 are nerve. And then you go back to the muscular. This is first technique which is recommended and everybody is doing. The second technique is,
But also recommended to do the radial first, huh? So you can get the...
yeah. It will go from behind, yeah. So this was the first technique, which is perineural technique. This I describe is perineural. This is now I am describing second technique, which is perivascular. In perivascular technique, you give 10 ml below the artery, 10 ml above the artery, forget, and then see where it is going. 20 ml is enough. This is minimum volume. If you give 30 to 40 ml, it is definitely blocking all the nerves. Nowadays, recommendation is 10 ml below the artery, 10 ml above the artery. You are done. You are in the... It will distribute. It will move. And if you are increasing the volume, you can find it is moving all around the neurovascular bundle, going up and down. You can see up and down. This is second technique. There are studies in the third injection. You can see 35 ml high volume below the artery. This is third technique. There are many studies which recommend if you give 35 ml below the artery, it will distribute. It will go up. This is a bundle. There is no compartment. There is no fibrous sheath. There is no fibrous sheath which can block to go up. If you give, it will go down, and it will move in the. It will bath all the nerve. So this is third technique. If you, yesterday we were planning to use this in vascular case done by this. Later on we found it was aneurysm. The book is a wound exploration of hand, and later on it was found. So I think who was with me? We were planning to give this 35 ml technique. So they say the studies prove that it works well. It never fails because the volume is high, and you are below the artery, means radial is gone, and then it moves. It will not go up. It will go down, and then nerves are around. So 35 ml means we are bathing all the neurovascular bundle. So it works. So these are 3 techniques we can use. One is perineural, 5-7 ml to each nerve. This is very good, perfect. All experts like to do this. We all like, because we have to enjoy the block also. We identify, we make a donut, and we are happy. And the second technique, 10 ml below. But this works. And the third technique, which also works, is 35 ml high volume. And we'll go. Thank you very much.
Thank you so much.
We are done. And if you want to discuss anything, welcome.